Dr. Tan Yia Swam.
Mr. Chairman, sir, I need to first declare conflict of interest as a general surgeon in private practice with an interest in breast surgery and my role as elected president of Singapore Medical Association. Escalating healthcare costs is a concern for many governments. In Singapore, this has gained much attention recently with questions raised by the public on private insurance agent. In truth, managing healthcare costs is a complex problem. Learned economists have studied it and there's no simple answer. I see a need for everyone to be part of the solution. I list 5 key factors. 1. Advances in technology leading to better quality of care. 2. Healthcare facilities costs. 3. Doctors' fees. 4. Patient health-seeking behavior. 5. Insurers. As research and experimental trials become validated, the advances will be accepted in mainstream clinical practice. One simple example in my field. 30 years ago, most breast cancer patients had to accept a mastectomy, and the resulting change in appearance was unacceptable to some. Now, patients can opt for nipple-sparing mastectomy and immediate reconstruction, which allow the patient to regain a physical appearance which is similar to her normal. This brings better outcomes for some patients, but clearly increased costs. Who monitors the cost of the private healthcare facilities? As a patient, when I receive the itemized bill, how do I know which of these items are reasonably charged and which are not? Doctors' fees have often been blamed as the main source of increased costs. How true is this? Historically, SMA had a guideline of fees since 1987, which had to be removed in 2007 as it was deemed anti-competitive. MOH announced in end 2017 that fee benchmarks will be implemented. Since then, the benchmarks serve as a guide on how doctors charge. Patients' health-seeking behaviors also affect costs. When people fall sick, how do they choose their care? Just take a Panadol and rest? See a GP? A TCM physician? Do they go to a polyclinic, the emergency department, or straight to a specialist? Finally, how are insurers involved? Patients factor in financial costs when they need to see a doctor. Some will go only to their company doctors based on their corporate insurances with no need to pay out of pocket. When they need to have hospital admissions, day surgery, or major operations, that's when their integrated shield plans will come in useful. In my budget speech, I highlighted the importance of shared decision-making in healthcare. We are in the age of patient empowerment. This has been so for quite a few years with an increasingly better educated population. The judiciary has acknowledged this trend when they introduced the modified Montgomery test, and the understanding was reinforced by this government when the Civil Law Act was amended last year. Patients must be adequately informed before they make a choice on the medical care that they want to receive. I am all for this, and medical practitioners here have been making adjustments in the way they practice, in order that patients are better informed and empowered. Likewise, insurers need to share more information and allow their clients to make informed decisions. From time to time, I get asked by friends and relatives about health insurance, especially integrated shield plans, or IPs in short. These questions include, which IP provider is better? Which IP plan provided by the provider is more suited to my needs? I must admit I am ill-equipped to answer these questions. I myself am insured with an IP, but I must confess that when I bought it many years ago, I did not make a detailed comparison of the various IP providers' offerings, but trusted my financial advisor's recommendation. Close to 70% of Singapore residents buy IPs, so IPs affect the majority of us living here. It is therefore important that Singaporeans are adequately informed upfront by the various IP insurers before they make a decision to buy an IP or before they make a decision to switch IP providers, since IPs are bought annually. I ask myself, what would I like to know before I make a decision to buy a certain IP or not? These are the most important questions that will make me choose one provider over another. 1. What are the premiums for me now and when I get older? 2. What are the benefits and claim limits of each plan offered? 3. What percentage of private sector specialists are empaneled by a certain IP provider? 4. Does the IP provider allow me to go to any private hospital in Singapore? 5. Are all restructured hospital specialists automatically empaneled? 6. How does the IP provider-based specialist? Does it follow MOH fee benchmarks? I realized that, other than the first 2 questions, information was difficult or impossible to obtain for me to make an informed decision on which IP to purchase. Questions about empaneling are important because ultimately it is about choice. The IP provider that offers more choices is more attractive to a potential IP customer. The last question about how IP insurers pay specialists is important in an indirect way. A system that reimburses private sector specialists adequately is more sustainable and better for me as a policyholder in the long run. More specialists will want to be empaneled with this IP provider, and I will have a wider choice. If my IP insurer does not pay the specialist fairly or adequately, how would the doctor feel? We can use the MOH fee benchmarks as a good guide for this. How does each IP provider pay specialists for procedures? Does a certain IP insurer pay up to the higher limit of the benchmarks, or the lower limit, or to the midpoint? Or does this IP insurer reimburse at rates that are even lower than the lower limit of MOH fee benchmarks? It should be a warning sign to policyholders when an IP provider pays doctors below or only at the lower limit of the MOH benchmarks. I think the regulators of IPs, which are MAS and MOH, can obtain the answers to these 6 questions from IP insurers and present them in a tabulated and easily digestible form that members of the public can refer to when they make their decisions on which IP to buy. This will advance the cause of patient education and empowerment. A more difficult but important policy question to ask is, what proportion of Singapore residents should buy IP? The combined market share of private hospitals, A-class and B1 class beds in restructured hospitals is estimated to be in the range of 30 to 35%. Yet, the proportion of Singapore residents buying an IP is nearly 70%. This is an unusual phenomenon in the running of a health insurance system. In the normal scheme of things, healthy insurance policyholders subsidize policyholders who fall sick and make claims. But in our IP environment, the business of IP is cross-subsidized not just by those who don't fall sick, but by those who fall sick and yet choose to be treated at subsidized B2 and C classes in restructured hospitals when they're entitled to more under their IPs. At a superficial level, it will appear that there's nothing wrong with this because it is the patient's choice and it is good to be prudent. However, there is an externality cost. When IP holders choose subsidized wards in the restructured hospitals when they fall sick, the consumption of these government subsidies are indirectly subsidizing the insurer's IP businesses and depriving patients in need of more subsidies, since MOH's budget is a finite thing. These government subsidies would not have been consumed had the patients chose what they were entitled to be treated in the private hospitals or in A or B1 class wards. Another important corollary of this unusual phenomenon is that it further lengthens the waiting times for subsidized services in restructured hospitals. I think it is important that we study this voluntary downgrading phenomenon so that we can ensure that the IP environment today is functioning faithfully to the original policy intent of IPs. Also, what is the desired proportion of Singapore residents who should buy IPs? Is it the current 65 to 70%? Or below or above this range? I do not know the correct figure. But with a private sector market share of only 30 to 35%, including B1 and A-class beds in restructured hospitals, the corresponding figure of 70% of the population having IPs sounds rather high. Can the private sector support the needs of this 70% if all of them who fell ill chose the unsubsidized services they're entitled to under the IPs? I have a few patients who themselves are insurance agents, and they realize they don't quite know what they are covered for. Are all insurance agents well trained and up to date about the products they are selling? Are the medical underwriters also keeping their medical knowledge up to date? I raise one specific and very common example in my view. A healthy lady in her 20s with no family history is offered a free health screening when she signs up for an IP, including ultrasound of the breast. This picks up a 3mm nodule, too small to characterize. This lady is then informed that she will be excluded from breast cancer coverage. Thereafter, there's a cycle of an agent asking her to see a doctor, the doctor telling her it is likely benign and can observe. The agent may then ask for a memo to state that she does not have cancer. I have met patients where they state that the agent has asked them to pay for the surgery themselves to remove the lump and then appealed to be covered. As a breast surgeon, I don't know how to help this group of affected women. There are no good medical indications for any of these. In summary, escalating healthcare costs is a complex problem, and the medical professional bodies are ready to be part of the solution through honest, open discussion. I call for increased transparency and accountability of insurance companies and their agents. MOH and the SMC scrutinize doctors. Who is scrutinizing the other players in the healthcare cost equation?